We think the only way we can transform healthcare is really a combination of two key factors. How do you redesign the workflow? How do we really take what we can do and put it into a very different, updated workflow? And then that has to be able to be supported by technology. And you can't do one without the other to actually get what we think is the ultimate transformation of a learning health system. And what I mean by that is that we can come up with new ways of seeing patients, of new ways of treating patients, but if it's not incorporated in a way that can scale, then all we are left with is little small pilot projects at one institution or the other. Conversely, you can't just throw novel technology or a great new shiny app at something if it's stuck within a workflow that won't allow that to scale, it won't allow that to get its greatest synergy of efforts and really transform care. So what we've done is we've taken areas of chronic care, predominantly in cardiometabolic areas, so lipids, cholesterol, and high blood pressure, and tried to identify what are those very well accepted therapies that everybody would agree should be done, but we know aren't being done, even in some of the best institutions in the country. And then how do you help the doctor do better care for their patients? Part of the problem is for the right thing to happen for a patient, it usually requires that the doctor and the patient are in the same physical location, and that everybody's got to remember something needs to be done. They've got to know what to do. They've got to have the ability to do what they have, and they have to have the time to do it. And there are so many problems with that we allow care not to be done the way we would want it to be done. So what we've created is a couple of key features. First, we try to identify patients through the existing electronic medical records. And because there are so many deficiencies in that, because there's so many areas of poor data collection, we have to do different types of machine learning and rule-based algorithms to try to identify those patients. Secondly, we really do think that we need to be able to build a system that the doctor doesn't need to be the center of every interaction, and that we can task shift many of the routine aspects of care to either physician extenders like pharmacists or nurse practitioners, but even more importantly to non-licensed personnel, and we call them care navigators or patient navigators, who are non-licensed people who are the real front face of our program. They're the ones calling the patient, helping to organize the patient, relaying the treatment recommendations, making sure they're getting their labs, making sure that they're getting their prescriptions filled. And the reason they're able to do that is because they're working within a very constrained algorithm of care that is then supported by technology, so that is taking data from the electronic medical records, it's taking data from the patient, it's taking data from devices, it's integrating that data, and based on that, our treatment algorithms, which are designed by our experts, are then being implemented automatically with the patient not being required to come to the hospital, not requiring them to come to the office, and it can be done at home. And so, for example, when we treat people with high cholesterol, we can help them get them on the right medicines, most of which are generic, to get their cholesterol under control. And all we need to do is be able to talk to them and make sure they get labs drawn, and they can get those drawn at the most convenient place for them. If we're talking about controlling blood pressure, it is having a blood pressure cuff that is integrated into our system so that the data flows to us, and we can turn around their blood pressure titrations in a weekly basis because we're getting their blood pressures. So things that used to take months, if ever, to happen in regular clinic, we can get done in weeks. And we've shown that we've had reductions of cholesterol in about 40%, LDL over a 3-month time period, and we showed blood pressure control within 8 weeks in the majority of patients, just because we've been able to do these rapid iterations. We see the value actually plays out on everybody in the ecosystem, and that's what's a little bit odd, is that we feel that everybody should be able to get real benefit from this. From the patients, it's a couple things. First, we're trying to improve their experience with the medical field, that we think that we can provide a higher touch model even though they're not coming in for visits as often. And we can push education to them, we can be the sounding board for any questions they have, and we can engage them in a way that most patients can't get engaged in a 15-minute office visit. They're getting better care. they're getting guideline-directed care, and that will correspond to reduced clinical events. For the doc, we really do see ourselves as an extension of their clinic, that we're offering them the service that we will take care of these very algorithmic, routine jobs that they don't need to do now. They can focus on what they're trained for, is much more complicated patient management when they need to actually spend time, and they don't have to spend time on their emails or their inboxes at the end of the day, titrating and changing medications. We'll take care of that, and they can focus on the important part of trying to integrate that. For a network, for a provider network, we think this makes primary care and even specialties work much more efficiently. They're able to open up more office space because we can take away many of those return visits and even initial consults that might be taken up with this, and they can fill that up with more patients and drive more patients into their contracts and into their provider panels, so that they can expand the number of patients they can touch. We also think, from a provider standpoint, this is a great way to try to enhance the digital doorway that every provider's been trying to figure out. How do I connect better with my patients digitally? And that's coming as people become more digitally enabled and more comfortable, but this is a great way, we think, to try to really help jumpstart that type of process. For payers, we also think this is a valuable tool for them, and we partner with one payer, Always Health Partners, in managing their members with lipids and hypertension, and for them it's a way of offering a service, a benefit to their members, additional to the other benefits they do, that is at no extra cost to that member, where we can manage their lipids and hypertension. And the payers and the employers are actually some that can see the greatest reduction. If you get these reductions in lipids and hypertension and other things, they'll see reductions in total medical expense that most typically go to either the payers or the employers. And so we think there's a valuable value proposition for them. And then for us in academic medical centers, we see this as a powerful research tool as well, to be able to build next generation clinical trials and discovery platforms, and to be able to actually work with the data scientists to be able to use this data, which we think is unique in that it's the longitudinal transactional data across thousands of patients that will be able to provide pretty powerful areas for machine learning and artificial intelligence to try to tease out some of the different signals in terms of how patients react to the different therapies and who does well and who doesn't, that would be very hard to tease out if we were just doing our normal database searches.